purposely presented this in this clinical meeting because people are not aware of what is going on in gynecology or urogynecology modern procedures. I think many people are not aware, and since this is a minimal invasive procedure and it's giving very good result, and we have been doing this even when Dr. Mishra was coming last 5 years, Amitabh was coming, I was doing it with them. We have been doing the procedures, but that time TVTO was not there because that time we had to take the help of urologists. We had to do a cystoscopy guided sling because it was going very close to the bladder. Now since TVTO has come, we are going to the obturator fossa and it is much away from the bladder, so the risk of bladder injury is much less, and now we have adopted this procedure. But the thing is that you have to select the patients very carefully. That is most important. And earlier what we were doing, we were taking a very thin vaginal epithelium dissection. So all this we learned from the process of doing it repeatedly. So now we are doing it, we are taking a very thick vaginal mucosa, and the tip has to be much inside. Then the vaginal mucosa has to be very thick, and the dissection has to be proper. The plane has to be proper. Only then can you avoid these kind of complications of mesh erosion, etc. Now it has become minimum, and this is a very standard procedure which is being followed worldwide with a lot of success because of the minimal. Because birth is a very morbid kind of a surgery, because birth has got a lot of venous plexuses in the retropubic space. It can cause hematoma. In fact, a patient was sent from BRC hospital to this hospital around 3-4 years back, who had a birch colpus suspension over the weekend. Patient developed hematoma. Patient died of renal failure. The patient had come here for dialysis. So this kind of morbidity can occur with birch and Marshall crunch procedures. So now this trial has occurred all over the world for the last, I think, 15 years because this has been already adopted, and FDA has approved of this kind of procedure, and this can be done for women. But the problem is our Indian women think that they have to live with this kind of a mess. They don't need a mesh, they don't need a surgery, they don't need any exercise. So first thing which I have to convince them is keep on doing your exercises. You have to counsel them, you have to show them the exercises, and these kind of things are very important because convincing them, they come to me for last 5-10 years, I show them the exercise. When the exercise fails, we give them estrogen cream at the same time. When that fails, if that is very severe, only in that case we do it, and it's giving good results.
So 5 years is a long time. How many cases you have done?
We have not done much. We have done 10 to 12 cases.
10
I
to
cannot
12.
give you a series like of the success rate, but worldwide success rate is, as you have seen, it is around 90-95%.
Last 10 days before there was some workshop, I think.
Yes. Actually, I had called him to put a ProLift. That's a different surgery. That's for prolapse, pelvic organ prolapse surgery, where you don't have any support for the pelvic pelvic tissue, endopelvic tissue, etc. When the total prolapse is there, when you don't have uterosacral support, the original supports of the ligaments and supportive tissues of the pelvis, when they're totally lost. So a huge procedure. Actually, that video was with me, but since this was not a platform to actually show you that procedure, I did not show. It is a kind of a, there are two mesh. One has 4 arms and one has 2 arms. So one we insert after we remove. You can do it either after removing the uterus or even without removing the uterus. Nowadays they say that earlier used to do Wadmios for pelvic organ prolapse, for procedentia. Now they say this, that is not actually the treatment for pelvic organ prolapse. We're doing chopping of the uterus, but we're not giving any support. So patient is coming back to 5 years, 10 years with the wall prolapse. So what we need to give the patient is not remove the uterus. That is not the problem. The problem is she has lost her pelvic support. She has lost all the supports in her pelvis. So we have to give her some support. And that in many cases when the original tissues have also failed, when you cannot give support with the autologous or her own tissues, then in that case we can actually put some mesh in. And that was the surgery which we had come to perform actually.
So you are doing it on general anesthesia or?
Actually, this procedure can be done even under local or under regional block.
Oh, wonderful.
Most of our gynae this can be done under regional block very easily, and it's a very short procedure, about 10 to 15 minutes.
Thank you for your good work.